Welcome to our third webinar in this series titled Caregiver, Lunch, and Unlearn. And this one is on autistic adults and mental health. So we're going to be having this will be an interactive unlearning of topics relevant to caregivers. And we're going to be focusing on autism and psychiatry. I'm delighted to introduce our presenters. Our presenters are from the Israeli Adult Neurodevelopment Center at CAMH, and it's the first research and education center in Canada dedicated to improving the mental health of adults with neurodevelopment disabilities and their families. The center is built upon 4 pillars, and that's clinical innovation, research excellence, education training, and knowledge and exchange. Through partnerships with neurodivergent people and their families, the center strives to build capacity and explore new ways of supporting the mental health and well-being of this group. And our presenters, we're going to welcome Dr. Amanda Sawyer, a child and adolescent psychiatrist, and Aideen, Nathan, and Leanne are going to guide the conversation, and I'm going to pass it over to them.
This webinar is not a clinical or therapeutic virtual space. We neither endorse nor oppose any specific therapy, product, treatment, strategy, opinion, and so on. We are caregivers sharing real experiences that may be uncomfortable for some. And so welcome. Aideen is going to get us started with a small exercise.
Hi there, I'm Aideen. If you could have the next slide, please. And I am a parent, caregiver, and I'm also, along with Nathan, program engagement co-facilitator at the Israeli Center. We're going to begin with a little word cloud, and if you can put in the chat, please, what comes to mind when you think about autism, mental health, and medication. And this can be a word, it can be a phrase, it can be a couple of words, and we'll have a little look and see what comes up in the word cloud. You'll see the most commonly used words will start to become bolder. And that absolutely summarizes confusion. This is something in our meetings and our discussions that's come up quite a lot. And
thanks, Aideen. I absolutely adore this photograph, and a little spoiler alert if anybody here has not seen Wizard of Oz. Today we are going to be pulling back the curtain, and we're pulling back the curtain on autism, psychiatry, psychiatric support, medication, and the reason why we use this image, for those who are not aware of the Wizard of Oz, again, spoiler alert, sorry, go back to my screen, is that after a long journey to meet the wizard who is going to magically help Dorothy get home, she pulls back the curtain only to discover that there is no wizard who is able to help her get back home. There is just another human who really, really wants to help. So my apologies, because there is a spoiler alert. Dorothy does get home with some help from the wizard, but she might have felt a little bit more prepared had she known what to expect. So, when 3 of the facilitators who are here today met each other, we started comparing notes and sharing caregiving experiences, and discovered that many of our firmly held beliefs about autism, mental health, psychiatry, and medication were really quite different from the reality. One might ask why we had specific expectations. I don't know. I think that some of us, when we picture psychiatry, we picture psychiatry in the movies. You go to your doctor, they give you medication, they talk to you, you sit on their couch, you have epiphanies, they look into the inner workings of your brain and your soul, and you really find the crux of the problem. And once you reach that point, you could start building on it and you can start to heal. However, life isn't always like the movies, and if you and your loved one are fortunate enough to have access to a psychiatrist in order for them to help you, they need to learn from you. They need to learn about you. They need to learn about your loved one. They do understand the science of medicine, but you are the one who knows your loved one best. In our experience, there is no couch. You might actually have one appointment if you're lucky with the psychiatrist, and you might have just one appointment to get in as much information as you possibly can. When it comes to medication, the reality is it is very unlike an antibiotic. There's a lot of guesswork, there's a lot of trying. There's a lot of try, and if at first you don't succeed, try, and if at second you don't succeed, try again. So you might be asking yourself, why are we pulling back the curtain? And you might be saying that this feels a little bit dismal and hopeless, and there's no wizard, and but this is an unlearn. And when we unlearn, we actually learn quite a bit. So our Unlearn today is about managing expectations around autism, psychiatry, and medication. It's about understanding the role that you as a caregiver plays. And in some cases, you might actually have no role here because this is a caregiver, you are caregivers with an adult loved one, and there needs to be consent for you to even play a role in this, in their psychiatric journey. So to help us unlearn today, we don't have an actual wizard, but in reality, we don't need a wizard. What we need is an empathetic listener. We need somebody who is a reflexive clinician, somebody who cares about autistic people deeply, who cares about their mental health. And on that note, I will invite Dr. Amanda Sawyer to help get us back to Kansas.
I'm Dr. Amanda Sawyer. I am a child and adolescent psychiatrist who prior to about, no, I don't know what my role is anymore, but I have traditionally had a lifespan approach to working with people with autism, even though I am trained as a child psychiatrist. However, I'm kind of leaning towards more working with children and adolescents right now. So I want to put that as a disclaimer for what I'm doing. But I do work with adults as well on the autism spectrum. And so I'm supposed to be the wizard, but I guess I'm pulling back my curtain and taking off the mask, which I think is very important to talk about sort of what can or be the role of medications and psychiatry with adults with autism and other developmental disabilities. Can we actually go back to that Wordle? Because I thought it was very important. I think this Wordle was really, really important as it came up and to see what the words came up were. And I think there's a few sort of things that are words that are really big. One is unhelpful, guilt, resources, limited, confusion, misunderstood, interconnected. And I think that really speaks to this whole unlearning or unmasking thing of what is the role of medications within adults with mental health issues and autism. And I think it's important to say that while a lot of these words are correct, there's two sides to it. And I think what the goal, as we were talking with the other panelists, is to sort of show the different sides of medications, the different sides of psychiatry, and the different ways that things might be helpful and unhelpful. So yes, it's right. I'm sure a lot of people in this room have had experiences with medications where medications has been extremely unhelpful. And there's been experiences where medications are also helpful. And it's a hard dynamic that we're playing. It's a hard road that sometimes we have to go on to find what's that balance between helpful and unhelpful, because there isn't a magic pill. And even when we look at our research, or if we look at the data that's out there for medications, I can't, if I was to be treating strep throat, I could look at the antibiotic resistance and susceptible panel and say, hey, yes, this is the right antibiotic for strep throat. I can't look at an individual with mental health issues and say 100% this is the right medication, because I can have a list of 4, 5, 6 medications that might be helpful or might have a little bit of evidence, for helping, but not a large amount of evidence, because there's no medication that has a large amount of evidence for adults with autism and mental health issues. The evidence we're often borrowing from a more neurotypical study base or population, which often a diagnosis of autism is excluded from studies. And I could take an educated guess about what might work, and I might be wrong, and I might be right, and I might help a little bit, I might help a lot, and I can't predict, and there's no sort of ball that can predict what medication can be helpful. And that could be a really frustrating journey, and that could be a really hard journey, because along the way, there might be lots of ups and downs, and a lot of uncertainty, a lot of guilt, a lot of confusion about what's working and what's not working. So I think one of the things that we talked about focusing on is how can we understand why an individual with autism might have mental health issues? How can we look at the mental health issues? How can we look at a multi-level way of understanding and maybe approaching mental health issues, so that medications is an option, and it may be something that helps. And we also understand what other things might have to be implemented in order to help the individual. Now, I'm looking at the chat. I just want to say I am not a researcher. I've been involved in research projects before, but I am a clinician. I am a frontline clinician. Sometimes some of the stuff that I do is involved in research, but I am not actually running any studies at this time. And I'm specifically not involved in any studies with regards to psychopharmacology at this time. So that's an important disclaimer that I should have. And I am not doing any of those studies anytime soon. We could talk about why, but that would be a different talk. So I think what we were going to talk about is we were going to go through sort of 4 pillars of understanding why someone might get to the road of needing medications. And so I was going to sort of go through them, and then I think with the panelists here, we were going to talk about sort of how that goes. So the first step that I want to talk about is what's the roles in actual medical issues in mental health. A population with autism is actually a population that is more at risk for having medical issues than a population without. And so we wanted to talk about the experience that medical issues such as constipation, diet, headaches, pain, medication side effects, how that might affect someone's mental health and how to understand it. So I don't know if I want to hand it over to Nathan, Edine, and Leanne a little bit to sort of talk about that, or whether or not some of my own experiences is what we'll bring up.
I'll jump in. I think that idea and that question about what we are treating is an important one. So, we talked, and I missed a little bit of that, so I wasn't sure if we were talking about the side effects or questioning what we were treating. So I apologize, I didn't hear the beginning of that. But one of the questions I think that comes up a lot is whether, like, for psychiatry, are we treating autism? Is autism does someone go to a psychiatrist because they are autistic, and what is it that's being treated?
So we don't have any medication that treats autism, and if we go in saying that we're treating autism, it's not the right target. There's no research to say that there's a pill that's going to treat autism, and in fact, I think the self-advocacy is actually saying. The self-advocacy is actually saying, hey, autism is not what the target should be. You know, the look for me is what is the distress that's happening around autism, and the 4 pillars that I'm going to look at for that is whether or not there's any medical issues that might be causing any distress, whether or not there's anything in the lived experience that's causing distress, whether or not there's anything in expectations that's causing distress, and whether or not there's any underlying psychiatric overtone that might be causing any distress. Where the medication target needs to be is more of that, whether or not there's any psychiatric undertone or comorbidity um, that can be treated with that. The issue with any psychiatric undertone or comorbidity that's happening is that if we don't look at things like what medical issues might be coming, we don't look at what the lived experience might be, if we're not looking at where expectations might be too high and low, and we just focus on one thing, we're not looking at the entire picture. And so we have to think, hey, you know, is someone constipated and really irritable, constipated? And if we treat the constipation, how are things might change a little bit. Hey, is someone really overwhelmed by everything that they have to do from day-to-day life? Someone really overwhelmed because there's so much social input that's happening from day to day? Is someone really underwhelmed because now school is ended or programming is ended, or you know, they can't find a job or they can't find volunteer work and they're really bored all day and they don't really have anything to do all day, and is that adding to distress? If someone had some significant trauma, which I think trauma is huge in the world of people with autism, and I think people forget that people with autism can have trauma, and forget to ask and talk about people with the trauma that people with autism might have experienced. And I think those 3 things have to be a part of the understanding of what might be happening from a psychiatric point of view, as opposed to just saying, hey, this one medication is just going to fix all. And I'm going to be very careful, and I'm not going to talk about any medication names, and I'm not going to talk about any specific medication target, because I can't tell you the medication that's going to help this person right now without understanding that whole part. And even when I do understand that whole part, I'm not a wizard. I can't say 100% this medication is going to work. I can say in my experience it's helped other people. I can say, hey, there's a little bit of evidence for this, let's try this, or let's go there. But I also have to have a certain level of humbleness, knowing that, hey, that might be helpful, it might be harmful, I don't know, and we won't know until we've tried.
And I was wondering, along what you were just saying about, for instance, about medical constipation, for instance, have you seen the health model that
So that
CAMH?
actually, I didn't say help, but that's actually, I don't know if you know what it is. I didn't help.
Yeah, it's help, and we can send a follow up. But if you want to, maybe it'd be really useful to maybe mention that. Yeah.
Okay, so I specifically didn't and so the help model is my Bible. So the help model is a model that was developed by Elizabeth Bradley um, um, about 10 years ago now, I think maybe even more, at Surrey Place, to talk about the full formulation of how to look at someone who has a developmental disability, who's coming in with behaviors that challenge the word that they specifically use. What it started out as is actually a linear process, that if you look at health, you have to solve all the health problems before you go to the environment or lived experience or psychiatric undertone. And I think over time, what they've realized is it's more of a dynamic issue. So for example, health issues might add to psychiatric issues, and psychiatric issues might add to health issues. And if you just look at one and you don't go on to the next, you might be missing pieces. So for example, if someone's experiencing a lot of pain, they can't leave the house, they might be getting depressed because they don't have a lot of stimulation. And so you can say, well, they're not going to stop being depressed unless you treat the pain. Well, actually, you know, we have to look at the depression as well as the pain. And if we treat one at a time, you know, the mood might be contributing to the pain might be contributing to the mood, And we have to look at both and both how they interact, and can't say, well, we can't treat one until another, because really they come together.
Thanks. I mean, there's so many questions in the chat. I don't know if Teresa, you're able to read some of them out, but before we get to that, I do. Somebody mentioned in the chat, autism is not a disease and not something to be treated or cured. And I don't know if anybody else here had a similar experience to what we went through prior to getting psychiatric support. Was speaking to physicians and other professionals who we were describing and working with my daughter, who told us, well, she's not struggling with, it's not mental health, she's just autistic. So the suicidality, the depression, the anxiety was all attributed to being autistic, and ending up in the emergency room as an autistic adult, being told, well, you're autistic, but really you have borderline personality because you're suicidal. So these are some of the introductions that we had to psychiatry. And I don't know, Amanda, if you are able to speak to what happens in a crisis and in emergency rooms, and how do we convey to other healthcare professionals, if we're even allowed in the room, that one can be autistic and struggle with mental illness and mental health.
My experience is that autism is not necessarily well understood, and I think autism that comes with people who are articulate, who quote unquote look normal, have a really hard time in the emergency department. And I'm trying to use my language carefully, because I think that's a really awful way to say, like, if you look normal, you're going to struggle. But I think that's also an experience that a lot of people in this room might know. And I think that, if you're verbal, if you're kind of talking in sentences, if you are able to communicate for yourself, the experience that I've gotten from people who I work with is they'll say, oh, they don't really get what the autism might be, or they might not really get how the autism might affect your experience in the emergency department. In my experience, places that have gone wrong is the use of collateral, or perhaps caregiver support or caregiver communication, is often something that's missed, and is something that can be very helpful. So I have people in my practice who have IQs of 150, way smarter than I am, who I ask, how are you feeling today? And they say, I don't know, like, that's a dumb question. Like, why would you ask me how I'm feeling today? And that's actually a really hard question for them to answer. And that's okay, right? They're able to answer other things in a way higher level than I am, but that question of how are you feeling today might be a really hard question. And if you go to the psychiatric emergency department, and that might be the first question they ask you. And so one of the advocacies that can happen, or one of the things that I think other healthcare professionals need to know, is that while you might be a very articulate individual, while you might be a very smart individual, while you might be very successful in your chosen field, relating things like personal experiences, personal feelings, personal medical issues might be something that's really difficult to do. So for example, I have people who have a lot of difficulties expressing their pain. I have people who have a lot of difficulties expressing their feelings, their emotional distress, their physical distress. I have someone who, they get constipated, and that's what causes a lot of emotional dysregulation. But if you ask them how often they're constipated, they'll say, oh, I'm not. And then if you actually go through it and have them do a stool diary, which in theory shouldn't be part of psychiatry, but in my psychiatry it is, and you say, oh, actually, you only poo once a week. Maybe let's try to get your poo a little bit more normal, and we'll see if that's if that's actually more helpful, that actually might be helpful. But you have to remember this idea that, you know, not all individuals are actually able to express their internal experience. And part of their autism might be not realizing what other people don't know about you, or not realizing your own bodily experience of what you might be experiencing, or not being able to say, hey, this is what I'm what I'm experiencing, but wanting to look quote unquote normal. So, you know, I have this really high IQ, I'm really smart, I'm, you know, doing my PhD at university. It's really embarrassing, or it's really hard for me to say, I don't know how to tell you how I feel, or I don't know how to tell you how my body is working.
What can we do as caregivers, knowing that at emergency, not everyone will be able to be as reflective or as observant as you are?
Well, and I
I
don't
wonder. Yeah,
department.
go ahead.
I,
Yeah.
I also want to put in a disclaimer. I haven't been in the emergency department since 2016. So I just want to, and I'm purposely out of the emergency department right now. And I have lots of respect for my colleagues who work in the emergency department. It's a very, 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 very hard job. So there's a few things that that I advocate for. One is having an understanding between the individual who has autism and someone who can help be their advocate. And I think this is a conversation that has to be had when mental health is in a good space. And I'm not saying a perfect space, because maybe mental health is never in a perfect space, but in a space where you can sit down and have a conversation. And I think if you have a conversation with the individual and with someone who you can trust to be an advocate, it might be a good thing to sit down and say, hey, listen, when I go to the emergency department, like, I want you to come with me, and I want you to talk with me. And it's good for the individual to know that they might have to start the emergency department visit saying, hey, my name is Amanda. I have a diagnosis of autism. It makes it hard for me to speak. I really need my caregiver to be a part of it. It might be helpful to write it down, because at that time it might be hard to speak and it might be hard to advocate for yourself. It might be helpful to have something that you just hand to the individual, sort of like a passport, where you go to the emergency department, you hand in something and says like, hey, I have autism. I need you to call my mom for extra help, or I need you to call this friend for extra help, or I need you to call X, Y, and Z. It's really hard for you to advocate for yourself. It's really hard to advocate for yourself in the emergency department. It's really hard to advocate for yourself in the medical system. It's hard for me to advocate for myself, and I'm a doctor, right? So I really get that this is easier said than done. I think that writing something down and having an agreement written down, is going to help bridge that gap, and it's something that I do encourage for a lot of people. But if you don't tell the doctor, hey, I need someone else to talk to me, with me, for me, whatever it might be, they're not going to understand that, and they're not going to look for that, because in adult medicine, you just see the patient. In child medicine, I see the family.
Thank you so much for that, Amanda. I'm wondering if we could maybe address a few questions in the chat. Lots of activity in the chat. Thank you, everyone. And I think following kind of on this conversation, attendee 107, you're asking if there's a checklist that a person or a caregiver can bring with them when they feel like to help when you're speaking to healthcare providers. I'll just say there are definitely some tools and forms that exist. They're excellent. We'll include those in a follow-up email so that you have easy access to them. Unless, Amanda, did you want to comment on anything specifically?
No, I was gonna say there are, because the age card, so that used to be part of my research when I was doing research, was figuring out how to make those checklists and how to make those helpful. I am a big believer of writing things down. I'm a big believer of checklists. I think it's extraordinarily helpful when people come to me and they give me a checklist or something written down. People who've worked with me know that I like things like records, calendars, that kind of stuff, because what it does is it gives you objective evidence of what is bringing you here to the emergency department today, and it gives you an ability to lay it out without feeling like you have to fight. The line that someone once told me that I think is so helpful is, you don't go to the emergency department because it's fun, right? It's not like you wake up in the morning and you're like, oh, I really want to go to the CAMH emergency department today. Like let's go. You go to the emergency department because there's something that's distressful for you. And there has to be, you have to be a little bit loud for people to hear you. Like it's not my favorite part of the healthcare system, but it's part of the reality, because people will see your diagnoses and say, oh, we have a diagnosis of autism, borderline personality disorder, whatever it might be. This is your baseline. And if you have an objective list of what your baseline looks like, and an objective look of what your why you're off of your baseline now, that could actually be a really helpful thing for the person seeing you today. Because they'll just say, oh, you have autism, that means you just like this. And it's like, well, actually, this person does have autism, and this isn't their everyday presentation. There's something different about today. There's a reason why today I'm coming to the emergency department. But the more documentation you have, the more objectivity you have, the more organized you are, which is really hard to do. I'm really bad at that as well. The more they can hear you. But that's what I'm thinking about. Where are you off your baseline? Why is this day different from every other day? That makes you say, okay, today's the day that I went to the emergency department, even though I've been in distress for 2 years, even though I've been hit every day of my life. Why is it today different? That makes you say, hey, I actually need help today.
Thanks so much, Dr. Sawyer. I'm wondering one more question. So I know we know wait times are a big thing. And I'm wondering so there's a question here, wait lists to get a child psychiatrist are long, 7 months. We know that. Any suggestions for the interim? What if there's like an urgent need of medication? Any guidance around that?
Yeah, it makes me so sad that there's such like I can tell you that I went into psychiatry thinking that I'd see everyone that I wanted to see, and that I'd have a short wait list, and I'd see people for a weekly psychotherapy, and I'd have a couch. I don't have a couch. I have a room full of toys, I don't know, and sensory stuff, which makes me happy. But it is a very, that idea of what does a film psychiatrist look like versus what a psychiatrist looks like in real life. I can tell you the stereotypes I do have, but I don't have the practice that I thought I would have. I'm graduating from medical school, graduating from my psychiatric training, because the system is a really hard system. And I found myself in this balance of, I can see like 5 people really frequently every single week and provide them with this level of care, and then my wait list goes from 6 months to 5 years, or I can see a lot of people. I could see them for a very short period of time. I could see them one time, and then my wait list goes quicker, and I'm not necessarily giving them the care that I wanted them to give. And that's the balance, and that's the hardship. And I'm trying to figure out what's the balance between two, because neither of them are all that realistic, and neither of them are doable. And it's that's been my struggle as a practicing child psychiatrist who specializes in people with developmental disabilities, is how do I balance it? And I don't have a good answer for the wait list. I think about it all the time. It's on my shoulders all the time. I can only work so much, and I'm only willing to work so much. And there's only so many people, unfortunately, who are accepting people who have these diagnoses as well, which I don't think is fair, but it's the reality we live in at this moment. So what are things that you can do to help yourself in the meantime? I think looking at that help model and thinking about how that help model might be relevant to the individual can be really useful. I think recording data can be really useful. And I say recording data with a whole lot of respect, because I know people are burnt out. I know people are tired, and the last thing they want to do is then go to a calendar and record every single time they're hit or something like that. But it is something that's really helpful. Looking at what are the organizations that you can sign up for that might provide services for in the meantime, what might be available through something like Ontario Autism Programming if you're eligible, DSO if you're eligible, other organizations, CMHA if you're eligible, Coda Case Management if you're eligible. But looking through the non-medical models is also helpful. And then thinking like, hey, is there any pain that I can help with? Is giving something like Tylenol something that's useful? Can I help with constipation? Can I help with sensory needs? Can I look at, withdrawing from loud spaces, wearing headphones, using fidget toys or squeezy toys or something that might be helpful, and recording what you're doing and recording what's helpful and what's not helpful. In theory would be helpful, but I know people are imperfect, and these are all theoretical, and you have to sort of be okay with whatever you can do is what you can do. Sometimes you don't have the energy to do anything, and that's understandable as well.
Thanks so much, Dr. Sawyer. I just want to address a 119. Do these things apply to everything you're saying with ongoing care rather than only just emergency care? I think so. And if that's in regards to like the tools and writing things
Yeah.
down.
So for me, it's so my focus is mostly ongoing care more than emergency care, because I don't do emergency care, right? Like it's just I have done it in the past. It's part of my training. I know how to get people to emergency care, but I could speak from my experience right now. What's helpful for someone who's going to do the consultation, who may or may not be able to provide ongoing follow-up care.
Thanks so much. There was one other question I was wondering if you could comment on, and now, of course, I've lost it. The comment was around, why is autism very difficult to recognize by family doctors when parents provide and I think it's like all the information or all the details?
So I think there's a trail of the DSM that's in there as well. So I can tell you, so I've been in the world of autism, developmental disabilities for 20 years, let's say. Yeah, a little over 20 years. It's been sort of an interest of mine. And I can tell you that over the past 20 years, the idea of what is autism has changed significantly. And so we've gone through several iterations of what is autism, what makes a diagnosis of autism, and we've gone through several different definitions of what makes a diagnosis of autism. So if you were trained at a certain point or time, autism is a disorder that's signified by a speech delay, which is actually part of the original DSM-5 criteria, and you have to meet some different criteria than perhaps what you have to meet currently, but one of the core features of autism had to be a speech delay plus a bunch of different criteria. Over the past 10 years, 15 years, they've actually rewritten what a diagnosis of autism is. And this idea of high functioning autism, or what used to be called Asperger's, has also been rewritten. So I have trained in several different centers in several different cities across Canada. And I can tell you that when I was training and there was the Asperger's diagnosis, when I went to one clinic in Vancouver and then I went to one clinic in Burnaby, what someone defined as Asperger's was actually very different in the two clinics. And then I went to Manitoba and it was different. And then I went to Ontario and it was different. And that's where the autism spectrum disorder actually came in, is there was a bunch of different diagnoses with autistic disorder, Asperger's disorder, PDD-NOS, that really didn't have good clarity between them. And people really were talking about two different things. Then what happened is autism spectrum disorder sort of said, okay, I'm going to encompass autistic disorder, autism, Asperger's, and PDD-NOS into one spectrum of disorder, and say, call it all one thing. Now there's still confusion, and there's always going to be confusion because people don't really understand what that level 1 autism looks like. or that autism sort of farther along the quote unquote high functioning, which I think is an awful word, spectrum, where a lot of people don't recognize those subtle signs of autism as a real thing. They're still looking for that Rain Man autism or that nonverbal autism, which does not actually encompass all of autism. But unless you were trained in the past 5-10 years, that's what you were taught autism is.
I noticed the comment from attendee 107 that currently autism is a disability, not a health condition. It can be chronic and need ongoing health support. There's a major gap that leads to a lot of crisis for the person and the caregivers. And I think, speaking as a caregiver, this is one of the difficulties we run into all of the time about diagnosis, as you were mentioning, about person first. And that provides quite a conflict, even when we have conversations among ourselves. I wonder if you had any feedback further.
And doctors are humans too. Doctors can only have so much information in our heads too. We have other responsibilities and other things that need to happen. And I could honestly say I try my best to keep on top of things, and I know I'm not. And it's going to be an impossible journey for me to be keeping on top of everything. I'm not smart enough. I don't have enough time in the day. And I think what's more important is, and I am a specialist, I have a huge specialty in autism, developmental disabilities, and mental health. I'm still not 100% on top of everything. It's just impossible for me to do. I think what's important is to have a humbleness to say, hey, yeah, you're right, I don't know everything. Hey, what can I learn from you? What can you learn from me? And I might be wrong. I might make a wrong decision. That is part of what I do on a day-to-day basis. I try not to make mistakes. I try to make wise decisions. I try to give good medications and good advice. Sometimes I'm wrong.
I just see a comment here. There are with physicians that don't necessarily fully understand the intersection of autism and mental health. How are we building capacity as well of doctors who are willing to work with this population? And I think are we seeing a change in the curriculum?
I think it's actually really important that we use research, we use teaching, we use conversations, all ways to create change. And we don't have a good system. We don't have a perfect system. And by talking about it, that's how we create change, right? So when I first started a long time ago, I came to Toronto thinking I would get really good education on how to work with people with autism and developmental disabilities. And I'd come out so well knowledge and so much experience and blah, blah, blah. And the truth is that when I first started, there were very few people who I can look to for mentorship and for understanding of this population. Over the past 15 years, there's been a big shift towards more people wanting to work with people with developmental disabilities and putting in the time to get extra training. So U of T has started a program to help teach medical students about working with people with developmental disabilities. They do a lecture series where people choose to spend extra time on a weekly basis learning about people with developmental disabilities, and that includes self-advocates as teachers. I'm having more and more residents who come and want to join me and are part of my clinic, who are looking for more expertise and more experience with people with developmental disabilities, where previously I had very few. So I actually have a hope. I think that this field of developmental disabilities is a wonderful field. I've devoted my career to it. I'm very happy I've devoted my career to it, and I will continue to do so. And I am seeing positive change that hopefully as time evolves, more people will be interested in doing it. And more people are interested in doing it. It's taken time, it's taken evolution to get there. But in the past 10, 15 years, I've seen a big shift, and I've seen a big change towards at least people wanting to talk about developmental disabilities and perhaps even learn about it. But it's been a journey.